Estàs entrant, ja?
Sí.
Vale, perquè quan hagis entrat, entraré.
Sí, entra, ja pots entrar, a veure si tot va bé. So, formally welcome to everybody to this new webinar in our GMI programs in meetings in dentistry. It's the second year we are doing it. We started in 2022, and we are increasing the participants in every single webinar. Today, we have the opportunity to attend a very interesting webinar provided by Dr. Daniel Digon. Daniel Digon is an implantologist and prosthodontist. He's Spanish. He was graduated in a university in Madrid, in Spain. He's also postgraduate in implantology in the University of Cambridge. He's also postgraduate in rotatory endodontics in Sendoline Institute in Silverstone. And he's also specialist in intravenous sedation for stressed patients in Queen Mary's Hospital in London. Also is postgraduate in prosthodontics by one of the most important societies in Spain. So Dr. Digon is going to talk about the emergence profile in conical connection. I'm sure that it will be very interesting, and I'm looking forward for your questions at the end of the chat. I repeat, please keep your microphones off and write your questions in the appropriate chat, and I will transmit those questions to Dr. Digon on behalf of you. So thank you, Dr. Digon, and go ahead.
Thank you very much, Domenic. Thank you for the introduction. As you said, today we're going to talk about the emergence profile in conical connection, why I use this type of connection to get the best results getting the emergence profiles, and why I choose this type of implants over other types of connections. As you said perfectly, well, my CV basically is I started as an implantologist in 2015, and I've been placing GME avant-garde implants since approximately 5 years ago. So I have a bit of experience with your brand and with this type of implant, with the GME avant-garde. And basically these days I moved back to Spain in 2018, and I have my private practice over there. And before, like you said, I was working and studying back in the UK. So just to begin with the webinar today, I think that the important topics that we have to talk about are the different type of connections that we have available on the market. I think it is quite important to review a little bit all of them and see why we choose one type of connection or the other, or which one is the best. In any case, as you will see, the conical connection is probably the best, but I will show you why. Then in the second part of the webinar, we will go straight into the emergence profile in the conical connection. And just to finish and make it a bit easier at the end, we will discuss a couple of clinical cases on how to get the proper conical connection in this type, the proper emergence profile, sorry, in this type of conical connection. Well, so just to start, as we all know, there is different types of connections available on the market. The typical one, the one that we used back many years ago, was the type of Brannemark, the external connection. I did use it the first year or 2 years, and then after that I started to move to the internal connections because the advantages are more relevant than on the finished one. We also, in the internal connections, we have to difference the different type of connections available. Because on the internal connections could be just simple internal connection, or could be internal and conical connection, or Morse connection, which are 3 different things completely. We will see the difference right now. basically the external connection. It has certain advantages and mostly it has loads of disadvantages. This is why I don't use it these days. The advantages that we can say about this implant basically are that there is a type of universal connection. So that means that with a normal transfer, usually if it's not from GMI, if we have this Phoenix implant, we can copy it quite easily with our transfers, and it's not as expensive as the other brands. But in the disadvantages, as we all know, there is little connection surface because obviously the crown emerges from this area. It doesn't go inside the implant. Due to that, the prosthetic screw, the crown suffers quite a lot of mobilities, lateral mobilities that allows or lets the screw, makes it loosen. So that gives us a lot of problems like marginal filtration, bone loss, and also we normally cannot get a good emergency profile on this type of implants. Why? Because these implants, we have to put it on the same bone level, at a bone level. It's not like the other implants that we can submerge them. So once you can submerge the implant, you can get more millimeters in order to create the good emergence profile. So in a Phoenix implant or normal Brandemark implant, it's really difficult or nearly impossible to get a good emergence profile. Second, we will have the internal connection, but not conical, which in this photograph, in this snapshot, we can see the frontier, which is from GMI as well. It has more advantages certainly than the previous one, but the advantages that we can say about this implant is that obviously it has a larger connection because the crown and the abutment goes inside the crown, so they will give less mobility to that complex. Due to that, we will get less filtration, less bone loss, and in frontier we have an extra that is not available in all these implants, that we have the polished neck. Disadvantages that we can say is that the price is a little bit higher, it's not universal, and it has a bad or limited emergency profile. We can get good emergency profiles if we have a thick mucosa. That is true. If the mucosa is, let's say, 3 to 4 millimeters mucosa, we can place the implant at a bone level and we will get enough soft tissue in order to create that emergency profile. But if the biotype of the patient is really thin, or we have 1 to 2 millimeters of mucosa, I will not recommend you to use this implant. I will go for the internal connection and I will submerge the implant in order to get enough biological space to create that type of good emergency profile. Then next, just I'm going to talk very briefly of this implant. I don't place these implants, but some people do, so it's good to talk about them, which is the monobody implant. It's an implant that has one component and is used basically when you have a narrow bone. I never used it, so I don't have experience with that implant, but it's a bit tricky, the implant, because when you have to do the prosthesis, if you don't place the implant in the perfect 3D dimension, it will be really difficult or impossible to correct the position of the crown in this type of implants. And then I just would like to explain you what is the Morse cone connection and what is it, and what's the difference between the Morse cone connection and the conical connection. I think that quite a lot of people confuse these terms, but they are not exactly the same. They are similar, but not the same. The Morse connection basically is a connection that was patented by an engineer. She wasn't a dentist, was an engineer back in the 1850s, and was a system of connection between two components of conical shape, which basically consists, like if we see a couple of glasses, basically it's the best image that we can get. Two cone surface fit together, and we find it really difficult or impossible to separate them. And we don't need a prosthetic screw to join this couple of components. With the conical connection, The difference is that we have this kind of Morse connection, but it's not as marked as in this case. And we always need a prosthetic screw to secure the crown. So that's the difference between the Morse connection and the conical connection, which most people don't know exactly the difference, but this is the difference. So I think that is quite important to know it. The most typical implant that has this type of connection is the Digon. I place not many, but a few Digon cases, which is the traditional Morse connection, which is wonderful, but has the disadvantage that is probably one of the most difficult implants to place. The advantage is that we will get a complete bacterial sealing because the crown, once it's placed, is very difficult to move. We can get also ultra short implants with this type of connection. And is retentive, as we said before, is retentive by itself. So it doesn't need a prosthetic screw, a passing screw that secures the connection. And now we're going to talk about the type of implant that I use in 95% of my cases, which is the GME Avantgarde. I usually use the GME Avantgarde, not the big one. The big one for immediate extractions and immediate loading is good, but most of the cases I use the GME Avantgarde implant. The definition of the GME Avantgarde is basically the definition that we have over here, that is a connection that allows the total adaptation of the implant in its abutment, as well as an excellent seal. Thus this minimizes the micro movements, and due to that, it preserves the bone. Once we get movements, we usually have bacteria leaked and we will get bone loss. So we want to avoid that as much as possible. As we can see, if we cut the implant, we will see this type of Morse connection, if you like. It's not like the Morse because it's a little bit more open than the Morse one. The Morse one has a conicity degree of 1.5. On this one, we will get like a 7.5. Depends the house of the implants. And then after that, we will have like an hexagon inside and a passing screw that will secure the restoration. So this is the type of implant that I use for most of my cases. As we said, the advantages and disadvantages are those ones that we will get a perfect bacterial seal. We will get more abutment implant contact surface because as we can see here, it doesn't stop there. It will go down there, the abutment and the crown. We can get, due to these implants, that we can submerge them without no problem. If we don't have enough mucosa, thick mucosa, we can submerge them, and between the bone and the mucosa, we will get those 4 millimeters that are required to create the perfect or the best emergency profile. And also it's an implant that, due to that lack of mobility, it preserves the bone better than other implants. As a disadvantage is like everything, it has like a higher cost. It's not an universal connection because each house has a different hexagon or connection down there and a different cone, and then require probably more expertise than other implants. Just to finish this part of the implants, I would like to show you this radiograph that I did a couple of implants for my sister. One was like 8 years ago, it was a Digon. And I like this picture because I placed a Digon, and then after that, 5 years ago, I placed like a GME Avantgarde, a 425 6.5 millimeters length implant. And as you can see here, this is a photograph, an X-ray that was taken 3 years ago. This is a post-operative X-ray of 3 years, and we can see that pretty much we didn't lose any bone, and they are pretty similar. They are not exactly the same. As we can see here, we have the passing screw, and in the Digon is like just a body that fits on the implant and doesn't move. Probably slightly shorter this implant than the one that we have on the GME Avantgarde. Well, we are going to start now with the part 2, which is the main part of the webinar. After we spoke about the implants, which is the emergency profile in the conical connection. With the conical connection, basically, we have a customized healing abutment like we can see on this picture. We can get a better emergency profile and create the adequate papillas on the area. If we use, for example, a normal abutment, it's much more difficult or nearly impossible to get the proper profile and create the papillas. So we will probably get some foot traps on the area, even if the prosthesis is perfectly well designed. On the right-hand side is a case that I did that I will show you later and explain later, which is with a GME Vanguard, and it's a canine. Was quite a tricky place because the patient didn't have much bone, and also the mucogingival junction, it was down there, so we have to do a bone graft and a gingival graft. But I explain you the case later. But as you can see, what we want with the emergency profile is something similar to that we have the zenith of the tooth in the right place. The canine usually is a little bit above the other teeth, so we have that in the right place. And also we have the papilla well created due to that type of emergency profile. We cannot get that with other type of implants. Well, just to start, the definition of the emergency profile, as we all know, is an emergency profile in dentistry simply defined as the contour of the tooth or dental restoration where it meets or emerges from the gingiva. So pretty much is what goes from the platform on the implant till the contour of the end of the gingiva. A good emergence profile is key to preserve the health of the implant and create an aesthetic result and generating back the papilla of the original tooth. Without a good emergency profile, we cannot get that. Then I would like to talk to you about the two critical zones that we have on the emergency profile, which is the subcritical contour and the critical contour, which we all know what it is basically, but it's good to remind it, which is those areas that we have over here. The critical contour is the area that most likely we will probably can see in the future if there is some recession, and the subcritical is the one that is underneath that area. It's quite important also the generation of good crowns with this kind of C-shaped area in order to protect the gum and the bone. So it's critical also to place the implant in the right place, in the perfect 3D-dimensional place to get that kind of prosthesis. Also, some important aspects to consider in order to create a good emergency profile. For me, this is probably the golden rule that I use in all my cases, which is called the 4mm rule, which is basically give enough biological space to the bone and the soft tissue in order to create that emergency profile. It depends how deep we have to place the implant in order to get a good emergency profile. It depends. Most people say you always have to submerge the implants. In the vast majority of cases, that is true, but in other cases, it's not necessary. We can leave it into the bone level or put it just 0.5 millimeters underneath the bone. Why is that? It depends the type of soft tissue that we have on the area. We always want to get between the bone and the soft tissue 4 millimeters. So say that we have, for example, a 4 millimeter thick tissue, mucosa. We will not need to submerge the implant at all. We can submerge it 0.5 if we want, but it will be not required. Then if we have like a 3 millimeter soft tissue, we will have to submerge it 1 millimeter. So we will get again 4 millimeters. If we have a 2 millimeter soft tissue, we will have to submerge the implant 2 millimeters. And if we have like 1 millimeter with those type of patients that have a very thin mucosa, we will have to submerge the implant 3 millimeters. So we will get the 4 millimeter rule in order. You can check this 4 millimeter rule in the book Según los Concepts of Thomas Linkevicius, which is over there, and you can check it in detail. but pretty much is that. We always need 3.5 to 4 millimeters in order to create a perfect emergence profile. Then the design of the crown is quite important. This is the evolution of the design of the crowns. These days, we try to do this type of design with a C shape, if you like, and getting some bone over the platform of the implant. That will be ideal, which is what we call platform switching. That will preserve the bone and protect the implant. Okay. So, as I said, it's ideal to have a subcrestal implant and allow the creation of the platform switching. Also, the anatomy of the crown, in order to protect that area, which normally is where is the thin bone on the buccal aspect of the implant, is important to place it palatally and get this type of C-shaped crown. And you can check all these concepts if you follow the umbrella concept that is perfectly described by Dr. Alberto Miselli, and as I said, in the zero bone loss concept of Thomas Linkevicius. Once we get the emergency profile, it's important to create it properly and also copy it properly, because most of the times we don't pay attention to the when we copy the emergency profile, so we're doing the job and then we don't copy it correctly. Back in the days when we don't have the intraoral scanners, it was a bit more traditional, if you like, the way that we have to create the emergency profile, to copy the emergency profile, sorry. So a way to do it, you could do it directly or indirectly. To create a proper emergency profile, we usually use a customized healing cap, or we can use a provisional crown. That will be the two ways to do it. And normally I do the temporary prosthesis for the anterior teeth, because obviously you are not going to live with the patient without a tooth in the front area. And for the posterior teeth, I don't like to risk it, so I normally use a customized healing cap. As I said, it's easier today to copy the emergency profile with the intraoral dental scanners. Why is that? Because it's really easy to do it. You just have to remove the healing cap, do the scanner of the emergency profile. After that, you have to put the scan body on the area, re-scan the area, and then feed back the abutment, and the lab technician has all the information in 3D perfectly to reply that with the crown. So that will be the ideal way to do it, with a 3D dental, with an intraoral scanner. Also, there is a system that I'm starting to use. I don't have many cases with this system, but I'm quite happy with the system, which is the Cervico system. Probably most of you heard about it or already use it, which is a system that you can choose the emergence profile that you would like to create depending on the tooth that you are going to restore. Say, for example, that you want to restore a premolar, it has obviously a different shape than an anterior tooth or than a molar. So basically what we will do is choose in this wheel the appropriate shape of the abutment. And with this bit over here that comes with the avant-garde, that is the driver abutment, because we use it to drive the implant in place, and then we can remove it and create an customized abutment with that. It's a titanium component. So what we will do is just use this bit over here to add some composite. We place it on the wheel, on the hole that we choose, depending on the tooth that we are restoring. We place the abutment over there, and then we fill it with composite. We remove it. We polish it correctly. It's quite important to polish, especially on the area that's going to be in contact with the gum, because otherwise, even if it's flowable composite, we will create inflammation. So that's really important to spend quite a few minutes to polish that correctly and don't have inflammation once we remove the healing, the customized healing cap. Another way to do it, which is how I do it more often, is that I place this driver abutment on the tooth, and if it's, for example, an immediate extraction, what I do is just fill it with flowable composite. I remove this component. I polish the area that is going to be in contact with the gingiva, and then fit it back again. And that way we are preserving, if it's in an immediate extraction in this case, we will preserve the shape of the crown that we extracted. So we are copying pretty much the anatomy of the tooth. So that's a way that works quite well, and it's pretty easy to do it. These days, I didn't use it yet, but I am starting to enter in the world of 3D printing, which is an amazing world. And these days we can create, with the same driver implant, we can create a customized healing abutment done, for example, with programs like Exocad, and then print it in our printer in the clinic, or we can ask the lab to create that type of abutment, which, as you can see here, this is not a photo of mine because I didn't did any of them yet, but as you can see, you can create the shape that you want perfectly. So this is something quite interesting that I would like to bring up. And then just to finish the webinar, I would like to show you a couple of cases that I did in order to create this emergence profile. The first one is the one that I showed you already at the beginning, which was actually for a friend of mine that it was to restore this canine over here. Basically, it was a patient that had an ankylosed canine, and we tried with orthodontics to put it back in place, but the tooth turned to be ankylosed. So unfortunately, the patient had a baby tooth. We had to remove the baby tooth and do several surgeries in order to get this result. In this case, I like to bring it up because I didn't use back on the day the customized healing caps, and I use ordinary ones, the ones that we can buy from GMI. And I restored the case with a tie base and a zirconian crown. The implant was a GME Avantgarde 375 and 8 millimeters length. I'm gonna show you the case. Basically, the initial situation, it was this. It was a very tricky case because we have the canine ankylosed on the area, which it was in contact with this lateral. We have to remove it with a piezo surgery in order not to don't damage this lateral. And also, the patient has the sinus really close to this area, which is not common. We exposed the sinus due to destruction, and we solved that with a membrane. And also the length of the bone, it was very short, as you can see here. So we have to perform a vertical regeneration on the area with this type of screws of Horizon. That is the house that I use, and with some sticky bone. We remove some blood from the patient, and we create that sticky bone to attach on the area. And that way we gain some bone, some vertical bone and some horizontal bone in order to place the implant later on. That was the first surgery that we performed. We also have to perform a second surgery in this case. I told you that it was quite tricky because the patient had the mucogingival line or mucogingival junction around this area. So in order to get a good thick mucosa, keratinized tissue, to create the emergence profile, we had to do a free gingival graft from the palate of the patient. So pretty much we have to do in the second surgery 4 months after the first one. We have to attach this free gingival graft on the area and wait for a month and a half, 2 months more in order to place the implant. On the third surgery, we have to place the implant. It was a short implant, but it's enough with this type of implants to hold a canine with no problem. It was a 375 diameter implant and an 8 millimeter length implant. As we can see, even when we gain some bone with the first surgery, we have to go into the sinus in order to do the internal sinus lift, as we can see here, I used the Densaver kit to do the internal sinus lift, and I add some extra xenograft bone to complete the augmentation. In this case, I placed the normal healing cap. Back in those days, I didn't use the customized healing caps. I think that the result is quite good, nevertheless, but these days I will prefer to use the customized healing cap. But as we can see here, the cap is quite close to the adjacent teeth, and the papilla that we got, as we will see in the final picture, it was quite good, or I think that the result was really good. And then I'll show you basically, this is the photographs from the inside. Basically, the emergence profile, it wasn't as wide as if we use the customized healing cap. But as we can see here, we have the gain that we got from the free gingival graft. And also this is the healing cap that more or less is close to the other teeth. So that is why the papilla in this case, it was created properly, because the emergency profile was enough. Probably could be better, but it was enough in this case. And as we can see here is the final result. We can say that it's not a final bad result. It's well integrated, and also we have the zenith of the tooth on the right place, and also the papillas are well formed. And I think that we can say that more or less it's a good result. And just a second case that I will like to show you, and I don't want to bore you anymore because otherwise I will keep talking forever. I'm going to show you how I do most of the customized healing caps. As I told you before, we use the driver abutment that comes with the GME Avantgarde. This comes with the Avantgarde, doesn't come with the peak, with the GME peak, even when it's conical connection as well. It just comes with the normal Avantgarde. And I like this driver abutment just to create this type of customized healing caps, because it's a component that is titanium, so it's quite strong and it will last and do the job perfectly fine. So how do we do that? I told you that before. We pretty much, in this case, we extracted the tooth. It was a tooth number 46. We extracted the tooth and we placed the implant in the same surgery on the septum of the tooth. It's quite important to preserve the septum because otherwise it's impossible to place the implant. If we get a good torque of the implant, we can do this type of abutment where we preserve the anatomy exactly the same like it was with the normal tooth, and we will get a result like that, which is, I think I would pretty much agree that is a result that we would like to see in most of our cases. As we can see, is the papilla over here, it will be created perfectly without no problems, and this is more or less the shape of the crown that we would like to create. With a titanium base, it was done. This is the phase one of this case. As we can see, we can identify a little bit the roots on the area. We have to place the implant on the septum of the tooth, so we have to preserve that, like we said. We also have to fill, in this case, it's mandatory to fill the gap with some xenograft. I always do it in every single case, but when you want to place a customized healing abutment and you want to put composite all around the abutment, if you don't have, obviously, something to hold this composite, it will drip down the socket. So we will not like that. So it's mandatory to put some xenograph or some grafting on the area in order to avoid that. With this type of abutment, if it's quite long, you can cut it. It's quite difficult to cut it because, like I said, it's a titanium made, and usually have titanium discs to cut it properly. But even with that, it's a bit trickier to shorten and trim it down the length of the abutment. But in 5 minutes, more or less, you can do it. So it doesn't take that long. once it's trimmed, you put it back on the implant, and then you fill it with composite. As you can see, that on this case, to get the 4 millimeters, we have to submerge the implant approximately in the bone 2 millimeters, and then we have 2 more millimeters of soft tissue. So we will follow the 4 millimeter rule that we explained before. I like this kit of burrs in order to give some extra torque to the implant, because what they do is they also densificate the area and give more torque to the implant. In this case, we got approximately 45 newtons, so it's more than enough to do all these procedures. So if you didn't use this kit, I recommend you and I strongly advise you to use it. I like it quite a lot. And then just to finish, like I told you, we use this component over here in order to create the healing cap. And well, pretty much is what I explained before. It's done with titanium, so it's quite tricky to cut it. So you must have a titanium disc or similar to cut it properly and leave it to the right length. And to finish, remember to remove all that once it's done and cure, light cure, to remove that and polish it. Once it's polished, you can put it back again, and it goes in contact directly with the bone graft. It's no problem. And after that, we will get the result that we saw before. Like I said, you can remove it over here and fit it on an abutment, and then over there you can polish it all around perfectly fine. And that way, when we remove the customized healing cap 3 months, 6 months, whenever it may be, we will not have inflamed gums. Otherwise, it will be a disaster. So it's quite important. Remember to polish all this area that is going to be in contact with the gum, with the soft tissue. And well, just the final picture. As we can see here, we have all the parts over here: the connective tissue, the junctional epithelium, and the sulcular epithelium that we would like to see in all the cases. And after 4 months, we could place the crown and finish the case with no problem. And we got this nice profile. And pretty much that's it. Thank you very much. I hope that you enjoy the webinar. I don't know if you have any questions. I will be really happy to answer them. And that's it.
Okay, thank you, Dr. Digon, for such an interesting presentation, such a clear presentation. I think it's been showed with clear tips, recommendations, and the benefits of this important type of connection. So I strongly suggest to everyone interested in placing a question, a doubt, or anything, please write it in the chat. Or if you can, of course, you can open your phone, but it will be too difficult to manage. So I strongly ask you, please write it down in the chat, and I can transmit the questions to Dr. Digon.
Don't be shy.
So
I don't know what time is it in different parts of the world. Maybe some people
no, you know,
wants to go to bed already. So
no, we have to really appreciate the people attending the meeting, because most of them are in the middle of their work, the daily work, in the
thank you.
practices, and they stopped for 45 minutes to attend this webinar. So I simply encourage you to write down in the chat any question you may have. Of course, you will have the opportunity to review again. I have a question, but just me finish. You will have the opportunity to review again the video, because you are going to receive in a couple of days the link to download the video, and you will be able to review it again. I have a question from Azar.
Mm-hmm.
he says, sir, sometimes there is implant failure in mandibular posterior teeth again and again. How to manage implant placement even if there is no periapical abscess or cyst?
Well, it happens sometimes. It depends if you are placing, I don't know if you refer when you are placing a temporary prosthesis or just with the abutment or with the multi-unit, because there are different cases. Obviously, if you are doing an immediate loading, it's true that with the back mandibular molars, due to the movement of the mandible, sometimes we overload these implants and they tend to fail more. So if you are placing, for example, 6 implants on the mandibular area, you will see that it's really, really difficult to see a failure on the anterior teeth, but the implants that fail more is the back molar. So I strongly recommend you to don't load the posterior molars because it's an unnecessary risk.
Dr.
So
Azar is clarifying that with abutment only.
With abutment only, with multi-unit or with customized abutment, well, it doesn't matter really. It depends how long is the abutment. Try to use an abutment and just leave it to the gingival level, because this way we will not have the interference of the tongue. Because most of the times it's just the tongue. When the patient is sleeping, you ask the patient nicely, don't bite on the area, and probably they don't do it. But some failures that I have really is always on that area that you mentioned. I don't have that many failures on implants, but when they fail, it's on that area that you're talking about. And mainly it could be just for movements on the tongue once they are sleeping, or probably that they tell you that they don't bite on the area, and they do. And also depends a lot how much is the torque of the implant that you place. I don't know how much torque do you normally apply, but normally if it's above 35, 40 newtons is fine. It's normally some parafunctional habits of the patient, even when the patient don't know that they are doing that, because like I told you, it could be sometimes very well the movement on the tongue once they are sleeping. They create this lateral movement that creates a lot of damage and doesn't allow the integration of the implant to the bone. So I think probably that is why that happens. But it happened to me as well. So thank you for the question. I don't know if I answer correctly or if you want some more explanations, but pretty much that's how I see it.
Azar is again clarifying that it is more than 45 newtons.
Well, if it's more than 45 newtons, also you have to take in consideration that sometimes you don't, if you place more torque than necessary, sometimes you can cause a necrosis on the bone. So normally I don't recommend to put more than 45 newtons on the implant, because if you over torque it, most of the times that bone will die due to the extra pressure. So I recommend you to put between 35 to 45 newtons if you want to load the implant or leave a healing cap. Normally, I don't have many problems when I do it that way. But if not, it's definitely a parafunctional habit that the patient does. So I recommend you really to probably lower the torque and try with that, and leave the abutments as close to the gum level as possible, because that way you don't allow the patient to put extra pressure. So leave it to the gum level and don't over torque the implants.
Okay, there is another question from Dr. Aftab Mirza. By the way, Azar is thanking you for the answer.
Thank you, Azar.
Let me see if I'm able to transmit the question from Dr. Aftab Mirza. Do you do bone mapping before placement? And he says 35 newtons per centimeter. I don't know if I have transmitted the question. I'm so sorry.
What do you mean with bone mapping exactly? Because I didn't hear that term before, so probably in Spanish it's a little bit different than If you can explain it a little bit to me, because probably I do it, but I'm not understanding the question correctly. Or maybe I don't do it.
Maybe
I don't know.
Dr. Aftab will clarify it by
Mhm.
answering.
Yes, please.
I encourage other people to place questions. It's a very good opportunity for all of us to really know more concepts and to understand much better about this conical connection.
With bone mapping, I don't know if you mean to do a CBCT or do a surgical guide, or what do you mean exactly by that? Because I don't know exactly what do you mean.
Any other questions?
Hello.
Okay, we have another question. Can we use Avant-Garde, the conical connection, in all on 4 cases?
Yeah, definitely. Why not? Well, it depends how you angulate the implants also, but yeah, I use it. I use it in not in many cases because I don't use. I don't do this procedure very often, but once I place it, I did it with no problem. Sometimes you have to, if with the all-on-4, as you know, probably we are talking in the mandible area. Normally the 2 front teeth, the anterior teeth, are straight, and then the other ones are angled a little bit just to save the mentonium foramen. So with the angled implants, it's true that it will be interesting to develop a tool just to trim down a little bit the bone in order to fit the angled abutments, because otherwise sometimes it's difficult to place these angled abutments on the bone. It will touch the bone. So some houses, some brands, they have this tool that trims and prepares the bone for the angle implants, and that way we solve that problem, because otherwise it's sometimes difficult to screw these angles, multi-unit angles. So I don't know if I answered the question.
Okay, I have another question
Mhm.
from Azar again. Thank you, Azar, for your
Thank you.
participation. Sir, what's your procedure for D3, D4 type of bones?
Wonderful question. For this type of bones, as I told you before in the webinar, I like a lot the Densaber kit. With the Densaber kit, when you have a soft bone, that happens, as you know, in the back areas, especially on the upper mandible, with this type of burrs, basically I can pass you a video how they work, because it takes a little bit of time to explain it. But basically, what it does is goes the other way around. So it doesn't go clockwise; goes the other way around. So what it does, it puts pressure on the bone surrounded the burr, and increases the torque of the implant. So when you have this type of implants and you want to place, I normally don't recommend, like I told you, a temporary prosthesis, but I recommend strongly to always put a temporary abutment. So I strongly recommend you to use this Densaber kit. It's expensive, but it's worth it, because it's a system that you can use for many different cases, as we saw in the presentation, for internal sinus lifts, for bone densification, as we are saying. And with that, for example, you can have a bone where usually you could get a 10 or 15 newtons of torque, and you can elevate that easily to 45, 50 newtons. Is incredible if you use it properly. I tried it before with normal burrs, and in areas that I placed 2 implants, and the bone density was really similar. Once with denser burrs and one with the ordinary ones, and the difference was massive. Like I told you, like could be like 30 newtons difference. So I recommend you to use that also for immediate loading, for cases of all-on-4 that we talked before. So I strongly recommend you to investigate on that. But basically how it works is how I explained. But if you put on YouTube, you will find many videos about denser burrs, and it's an expensive kit, but worth it. I don't know if I answered the question.
I guess so.
Thank you.
I have another question
Thank
from
you.
Javi in Spain. Congratulations, Dr. Digon, for sharing your knowledge with us. The question is about us customize the personalized abutment in a unitary restoration WS use versus use a biostatic base and don't lose the biological sealant. I don't know if, let me repeat it.
Yeah.
You understand the question?
If you can repeat it
Yes.
again.
Question is about customize the personalized abutment in a unitary restoration versus use a biostatic base and not losing the biological seal.
Understand. So you mean that in unitary cases that with GME Avantgarde you have the option of using this, let's call it multi-unit for single cases, like is what you are asking, I think. I normally go straight into the implant, so I cannot tell you, I just use it once, so I cannot tell you really much about it. But I prefer to create a best emergence profile just to go directly to the Avantgarde. Why is that? Because if you put that component, you are losing some height on the area in order to create the perfect shape of the emergence profile. But I didn't use it much. I usually prefer to go straight to the implant. It's true that if you use that component, you don't have to touch the implant again, which is quite helpful and it is beneficial for the implant. But it's true that if you have a thick mucosa and a strong mucosa, it will not matter to go straight into the implant. I never have any major bone losses or problems to screw the crown directly to the implant. So I prefer to go straight to the implant in single cases. Multiple cases, not. I always use multi-unit. Okay. I don't know if that was more or less the question, but...
Yes, Javi saying that that's it, and thank you very much.
Thank you,
I have
Javi.
another question from Alex Lawrence. Conical implant connection Avantgarde implants is coming with the mount. I understand he means the carrier. Can you tell me when we are going for the crown fixing, can we use the mount for the abutment?
Yeah, definitely. You mean the driver abutment that comes stick into the implant on the JME Avantgarde?
I guess it is. Yes, I guess.
Yes. Yeah, I think that I explained that before, but pretty much what it is that definitely you can use that because it's a really good quality. It's done by titanium, if I am not wrong. And it's the one that I use to create the customized healing abutments because it's much better than use, for example, a PIC that is sort of plastic. This one is stronger and is the one that I always use. And also, like it comes for free on the package, why not to use such a wonderful component when you got it for free on the package? Otherwise, it will not make too much sense to have it. But for these procedures, it's wonderful, the JME Avantgarde, because it comes with the extra component for free. So don't charge us extra in the future for that. So yeah, I don't know if that answers the question, but...
Okay, Dr. Alex Lawrence said thanks for your valuable information. So I'm just wondering if there is any other question. We are now 1 hour and a half. It's been a very interesting webinar with a lot of new messages and really, as Alex Lawrence said, very valuable information from Dr. Digon. I would like to know if there are more questions. Yes, I have Azar, very proactive participant. Thank you very much, Azar.
Thank you.
The question is, Sir, how can we proceed for immediate loading on extraction site of molars?
If you remember on the second case that I showed, for example, on a molar, imagine, for example, a lower molar. It's quite important to preserve the septum of the implant because imagine that you have on a molar all the roots connected together. If you extract the tooth, obviously you are left just with a socket. So you don't have really where to anchor the implant properly. So you have to do an odonto section. For example, imagine a tooth 46, a lower first molar. What you will do is, once you decide that that tooth needs to be extracted, you do an odonto section of the crown, and you extract the root separately in order to preserve the septum. That way, on that septum, you can place the implant, and the way to place it, usually that bone is not a hard bone, so it's quite soft. Like I told you, it's quite important to use the Densaver kit, because otherwise you will get like a 10 Newton torque or 15 Newton torque. So with that type of system, like I said, you could get like a 40, 45 Newtons without no problem if you use it correctly. So what you will do is just do the odonto section, remove carefully the crown, preserving the septum, proceed with the Densaver kit, install the implant, and also measure from that is quite important as well, measure from the septum to the contour of the gingiva on the top, how many millimeters do you have, in order to calculate how deep this implant has to go on the septum. Because imagine that the septum is quite close to the contour of the gingiva on the top, you will have to submerge the implant a little bit more. Imagine that you have like 1 millimeter. So we have to follow the 4 millimeter rule, 1 millimeter from the contour of the gingiva to the septum. So what you will have to do is, if you have 1 millimeter, submerge it for 3 millimeters, sorry, on the septum. If not, you have to calculate, measure that with a probe or with a ruler, that there is different surgical rulers that you can use for that. And you calculate that and give enough biological space in the future in order to create that emergence profile shape. So I don't know if more or less that answers the question. If not, I'll explain it better, but this is how I do it, basically.
Okay, Azaris, thank you again.
Thank you.
So if there are no more questions, I think it's good time to finish. As I always say, if any one of you still have a question, please direct it to GMI and we will forward it to Dr. Digon and he will kindly answer you by email. And you will receive, as I told you before, you are going to receive in a couple of days, 3 days, a link with the full video record of the webinar. You can check it again. And if there are more questions, more doubts, don't hesitate in contacting us and we will transmit it to Dr. Digon. So again, if there are no more questions, thank you everyone for participating in this new webinar. We are really proud of having you here, and it's an honor to host so many people from so many different countries. Thank you all of you for stopping for 1 hour and a half your job and your surgeries and your implants and so on. And we hope to see you soon because we will keep promoting new webinars to help you in your job. Thank you, and thank you, Dr. Digon, for such an interesting,
for having me.
For such an interesting webinar. And see all of you very soon. Regards.
Thank you. Have a good day. Bye.
Bye.